be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.
Good afternoon, everyone. Thank you so much for joining us at this afternoon's Lung Cancer Living Room. As you know, we have been bringing this meeting to you once a week for the last month or so now, in order to keep you updated in this rapidly changing new world that we live in. So welcome to each and every one of you. I'm Danielle Hicks, Chief Patient Officer at GoTo Foundation. I will be moderating the living room as usual today. For those of you that are missing Bonnie, and I know that a lot of you are, she is online. So I'm not certain if she's on Facebook or YouTube, but definitely look for her there because she will be chatting away as usual. I want to welcome our speaker today, Dr. Kavitha Ramchandran. She is a clinical associate professor, medical oncologist, specializing in thoracic oncology and particular palliative care. She's right down the road from us here at Stanford, and we are very pleased and honored to have her come and talk with us today. As always, a little bit of housekeeping. I want to remind everyone, please ask questions throughout. We want this to be interactive. We want to make sure that we're getting you the information that you want to hear about. So Michelle and Amy Moore and others from the GoTo team are moderating online in both platforms right now, and we'll be able to get the questions to us as you type them up. So if there's for any reason we don't get to one of your questions in this hour time frame, please don't hesitate to reach out and email us at livingroom@gotofoundation.org. That's where we're kind of filtering through all of the questions that are coming in through the meetings. And so with that, I want to jump right into the program because I know this is a little shorter program than a lot of you are used to when we do the regular living rooms. We only have an hour here today. But I want to start with Dr. Ramchandran just kind of telling us a little bit about why she chose thoracic oncology and palliative care as an area of interest, and then we'll jump into some more detailed conversation.
Wonderful. Thank you so much for having me. It's nice to be here with you all, and I'm just really grateful for the invitation. I've had the opportunity to know about Bonnie's work for many years, and also have the joy of interacting with many folks in the community who've really benefited from the GoTo Foundation and from Bonnie's efforts to bring forward lung cancer for our patients and to really improve advocacy for our patients. My story is, a story just like other stories. I think many of us who come into taking care of people who have cancer are motivated by personal reasons. And as a young kid, I was always motivated by taking care of folks who had serious illness. I felt very committed to understanding the trajectory of what it meant to go through something that was difficult and also understand what it meant to make decisions when encountering difficult things. And when I was younger, I used to volunteer actually in a dementia facility, and I would go, it was an Alzheimer's home. And when people got sicker in the Alzheimer's facility, they would move from one home to the next home. It kind of was a marker of their decline. And it was just very poignant to me to watch these changes in the life cycle and what families went through and what patients went through as their loved ones changed and how they grappled with those goals and hopes and wishes for their loved ones. And then I knew that medicine was really in my story. And so I went forward to do medical school, had the joy of doing it right up the street at UCSF. And I got paired with a oncologist as my mentor. And I was really struck by how beautiful storytelling happened and how willing people were to share their vulnerabilities in a setting that did not feel clinical, but really felt like home and really felt like a place for people to be willing to be upfront about what was most important in confronting some of the hardest phases of their life. And finding an ear in that oncologist who was willing to share a hug, share information, share a cup of tea or a brownie, and just really make it a point to know that that person was heard and that it was a story that was worth listening to and a story that was going to be important in developing that care plan for that patient. Along the way, I had a chance to meet a really, oh, sorry.
No. Go ahead. Keep going, please.
I was just going to say that I had this opportunity to meet this beautiful woman in my continuity clinic. She was a young woman in her 30s, and she was like me. She had just finished her PhD, and she was out there conquering the world. She just bought a house and got married, and now she was in an infusion chair. And I asked her what brought her there, and she said, "I have pancreatic cancer." And I was blown away, and I think I was just struck by her vulnerability and her honesty. And I think it just opened a door to me to learn about patient story through friendship. And we became friends, and I helped take care of her. And it was a really great opportunity to understand how it was to live with a difficult cancer. And really why I chose to do palliative care too, as I went forward in my career.
That's great. I think, so we're going to talk about palliative care today, what it is and what it isn't. And I want to start with sort of the what it isn't, or what you hear from your patients, and what their misconceptions or concerns might be when they first hear those two words, palliative care.
Yeah, so palliative care has a lot of power. The words have a lot of power. I think people often have a strong emotion when palliative care is brought up in their care trajectory. I think initial thoughts are, is my doctor giving up on me? Am I dying? What is this a place that I go to? Does that mean I can't get chemotherapy anymore? I think there's often a lot of fear around the term palliative care, and with that fear comes a level of anxiety and resistance that they're not ready for palliative care. Interestingly, patients are not alone. Doctors sometimes feel that way too. We'd often recommend a consult for palliative care, and physicians will say, well, my patient's not ready for that yet. We're not at that point. We still have a lot of treatments to offer. And so I think there's this very strong connotation that palliative care means that we are not offering additional treatments, or that we are transitioning care, or that we are approaching end of life. And that raises fear appropriately for patients and families when it's introduced to them.
So it's interesting that you say even physicians maybe misunderstand the role that palliative care should play, and that there's confusion even within healthcare professionals around palliative care versus hospice or end of life care. Equally as important, but totally different. So
totally different.
So we've got a lot of work to do on both ends in educating, it sounds like the healthcare professionals as well as the patients as to why they shouldn't be fearful of palliative care. Can you talk a little bit and give us some examples of what palliative care actually means? What is it?
So palliative care in the strictest sense means to relieve suffering. So it means to relieve suffering. And when we are given, we don't want it, but when we are given a diagnosis of a serious illness, and we move from that phase of our life where we've always felt healthy, like nothing could defeat us, and then suddenly we are vulnerable. We are vulnerable in a way that we have never been before. And we're vulnerable mentally, physically, socially, existentially. We've moved from that phase of healthy to not healthy, from well to sick. There is a form of suffering in that. And that suffering is quite great. And I think that the role of palliative care is really to relieve that suffering and to create pathways forward, that even with serious illness, even with a diagnosis that's affected your identity and affected your social life and affected your medications, there's still a really clear path forward where you can have control and you can have good quality of life and good function, and you can achieve your goals. And so it's really about relieving that suffering and about creating that pathway forward that's about empowerment at all of those different levels, whether it's physical, psychosocial, spiritual, but creating that robust way to help people to continue to fight, to stand, to be with their illness.
So how do you determine, is this a conversation you have with all of your patients? Or how do you determine whether or not it is appropriate to start having this conversation with the patient? What are some of the sort of, check boxes or red flags that might lead you to think this person needs more support than just their regular clinical care?
Yeah, that's a great question. And I think we think of palliative care in two different ways. One is primary palliative care, and the second is specialist palliative care. So primary palliative care is some of the work that your doctors are doing in the room with you, your oncologist is doing in the room with you. So if your oncologist asks you about whether you have pain and how that affects your function, and whether or not you're able to work, or whether or not you have an advance directive done, or how are your children doing, that's all a part of palliative care. And for most of us as oncologists, we take great pride in knowing our patients, knowing who they are, knowing what's important to them. And so we build that into our care. So that primary palliative care piece. There's some patients, though, that need more support. So they might have complex pain syndrome that arises because of their chemotherapy, or they might have, very complex decision making in their family because of language or culture or religion. Sometimes they just need a space to talk about things in a way that's different than from their oncologist, so that they can really, vent a little bit about, how sucky the chemotherapy is, or the fact that they would rather be, at their friend's, wedding rather than doing this bone marrow transplant. Or so it's just a very it gives them that honest space to really communicate with a different provider, a neutral zone. So I think if you have a great oncologist, you're going to get some really good, solid palliative care already. But if there's additional pain needs, symptom needs, psychosocial needs, anxiety, depression, complex decision making, complex family needs, or you just need another ear. Like you need somebody else who can just bounce things off with you and say, hey, I'm thinking about option A versus option B for my treatment plan. Or I wonder what it would be like if I took a treatment break and then did this instead. Or I'm really fearful about the oxaliplatin or the Alimta, and I just need another ear to really talk through things. That's also a really good reason to refer. And I refer for all of those reasons, and I get referrals for all of those reasons as well.
When we were talking before and having a conversation about what we were going to talk about here, you said something to me that really resonated with me, not only personally but professionally, in talking with patients all the time and hearing them share some of their concerns. And you talked about one of the big sort of purposes or points behind palliative care is to ensure that the patient's voice doesn't get lost in the care plan, right? Can you give some examples of how that? So let me step back for a second. I think some of the things we've already touched on, I want to dig a little bit deeper into, because quite often I think patients are fearful of going to their medical oncologist with some of these things, particularly as they pertain to pain or side effects, because they think that might mean if I go and start complaining about it, they're going to take me off this drug, and I really want to stay on this drug, right? So can we talk a little bit about that sort of shared decision making and why, in my opinion, and I'd love to hear yours, it's so important that it happens up front, not when we're 6 months down the road, in a patient's treatment, but that upfront conversation, so they never get to that point where they might be fearful of having that conversation.
Yeah, I think, the shared decision-making piece is so important. I often say that the content of what you get in a visit is often informed by the context. So when I see a patient in my palliative care clinic, I get very different information from them versus when I see them in my oncology clinic, because I actually run 2 different clinics on 2 different days of the week. And in my palliative care clinic, people come ready to talk about their psychosocial needs. They talk a little bit about their treatment toxicity. They talk about existential crises and what they're going through. And so I get a little bit of different data. And then when I'm in my oncologist hat, I have good data, but it's not often as full. And it's usually how they're functioning the week before, whether they've had any side effects, what their labs look like, what kind of support they're getting at home to do their treatment. And so when you combine the 2 pieces of data, it's really full, right? It's really helpful. I can start to have a complete story about what's happening in that person's life. So not only how are they tolerating the treatment and how are they doing physiologically, but what's happening at home, what are their goals? What are they hoping to achieve? And you bring it together, and then you're able to really come up with a very thorough care plan. And I think, so I answered the latter half of your question first. I just want to make sure I answered it fully, or if you had any thoughts about that.
No, yes, I do. I was going to say no, but I always have thoughts about things. How does this work in an environment where maybe um, your medical oncologist and your palliative care physician aren't connecting? Because I hear what you're saying, and it sounds brilliant to have that whole sort of story with the patient, not just what are their medical charts look like. How might that work in an environment where there's not the benefit of either your medical oncologist also being your palliative care physician, or them not connecting the dots?
So I would say that I'm usually not the oncologist and the palliative care doctor for any of my patients on purpose. I'm either their oncologist or I'm their palliative care doctor. For my oncology patients, I would say I do excellent primary palliative care. I try my best. So I incorporate the palliative care into my oncologic care. But for those patients who need more support, I'll still refer them, because I do think that different point of view does give you different information. I think that the goal of palliative care, our main tool in our toolbox, is communication. So we wouldn't be good palliative care doctors if we weren't communicating with the oncologist, and if we weren't actually explaining what was going on for the patient and what we were seeing and what they were hoping for. And so if there is not a good connection between the palliative care doctor and the medical oncologist, then probably someone's not doing their job. And the palliative care doctor really needs to step up and communicate with the medical oncologist. And ideally, that opens up a two-way street where the medical oncologist also feels committed to communicating with the palliative care doctor, so that they're really making a plan together. In an academic medical system like Stanford, I sit on the same floor as most of the cancer providers. So the communication is really straightforward. We walk down the hall, we say hi, we talk about patients, or we do it through the EHR, electronic health record. Even in places like Kaiser and other big non-academic medical systems, they usually do have outpatient palliative care now. If you're in a system that the two are truly separate, I think that sometimes patient advocacy goes a long way, and having a patient advocate or a loved one saying, hey, can the two of you talk? I really think it would help my loved one's care be better if the two of you really commit to talking and communicating about a care plan. So those are the different approaches. But in the same way that we communicate to our patients and families, we really need to communicate to the surgeons, the medical oncologists, the radiation oncologists, the primary care providers. Otherwise, we're not doing a good job.
And sort of a follow-up to that is this always a referral process, physician to physician, or can a patient request a palliative care appointment?
It is both. So patients can definitely self-refer to palliative care for sure. And it's great to self-refer. It kind of depends on different people's insurance. But physicians can also put in the referral. And if you feel like palliative care is a good choice for you, it's always great to ask your physician for a referral to palliative care, and they'll be able to do that for you. So it's really goes both ways.
Great. One of the things you mentioned is that palliative care is forever care. You've said this to me before, and how it should carry across the care continuum throughout as the disease evolves and changes. Let's talk a little bit about what might a first appointment look like for a patient who's coming in for their first visit.
Absolutely. I actually wanted to ask if you wanted to go back to your first question, which
Oh,
was about the patient's voice.
yep.
I did want to comment on that a little bit. I think, I don't know about you, but medical care has gotten so complicated. We have often 5 doctors, 6 doctors. We're often in inpatient care and outpatient care, radiologic care, surgical care. Um, you have an ostomy and a catheter and a chemo plan and 18 people you could message on My Health or your Epic streaming app or to get things done. And sometimes patients just come to me and they're like, I don't know who to talk to anymore. Who's in charge of me? I know my cardiologist is in charge of my heart, and my nephrologist is in charge of my kidney, and my oncologist is in charge of my cancer. And I just don't know who's in charge of me, like all of me. And and I think that where we may not be someone's primary care doctor, we do care about all of you. And we do care about making sure that you're not lost in the shuffle. And if you do have 18 doctors and 6 things going on, if someone says, I just have this appointment for this random thing in 3 days and I don't even know who I'm seeing or why I'm seeing them, it's okay to ask your palliative care doctor about that. I'm like, I will figure it out. I am going to find out why you're seeing this person, why it's important, who cares to take care of you. And sometimes they'll come to me and they'll say, I'm really afraid to tell my oncologist this. Like, how do I phrase it in a way that I won't upset them or disappoint them? And so I'll come up with ways to soften that communication and also sometimes say, can I help you with that? I can, send a message and start the conversation to iron things out. So it's, and the hope here is that we're really making sure that the patient's goals, the patient's goals, the patient's wishes, the patient's desires for what they want to achieve are occurring. And all of the things that we're doing, whether it's chemotherapy or a surgery, all of those things that we're doing are to achieve those goals. And if we're not achieving those goals, then we're probably not doing the right thing. So, how do we make sure that those plans are really in alignment for goal concordant care and we're working together in lockstep in a coordinated fashion to achieve those goals for patients, and kind of really removing some of that, the confusion and the lack of coordination from the milieu so that people really have that advocate who's saying, actually what's most important is that I can, get to my daughter's wedding, I can, continue to work, I can pay the bills at home, and whatever those things are that are most important, are these treatments allowing you to achieve those goals? And so that's our job. And I think it's fundamentally why we do what we do and why I care about what I do. So I didn't want to leave that.
Yeah, no, I'm glad you didn't, and apologies, and everything you just said is so important for patients to hear and physicians to hear and understand. This is not a one size fits all space where you can just, to use the check the box reference again, you can't just start checking boxes and assume it's going to work for every patient that walks in the door. So I love what you just said.
Yeah.
And I also think that that's a perfect segue into,
Yeah.
I think we kind of discussed about a little bit about misconceptions, what it is and what the hopes are around, what palliative care can provide to the patient, to help. And we've had the conversation about how hopefully we have eliminated some of those fears from people who are watching now or will come back and watch later. But what can they expect from a first appointment? Like, how do you go from, hi, you're sitting in my chair, and maybe they were referred to you because of, some sort of pain management situation or something, but they've really got these other things and they don't know that they can even talk to you about it. What is it? How do you
Yeah.
get there?
So I want to just tell you that pre-COVID and post-COVID, you can still see palliative care. So
Yeah, no, and I want to end with how we can still do palliative
oh
care
yes,
today in
okay.
this time.
So
Yeah.
I'm going to tell you kind of how it works in the normal world, and then we can talk a little bit about the COVID pieces. But in the
Right.
normal world, a patient would come and see me in clinic. We actually have a very different type of team structure. We have a chaplain, a social worker, a child life therapist, in addition to a nurse and a physician. Patients come in and they do an intake with us, and that intake includes a symptom assessment where we do a very thorough understanding of, do they have pain, constipation, fatigue, mood problems, and then we do a functional and social assessment. So are there any sexual health needs, spiritual health needs, financial needs, any issues with sleep or finances? And there's like a psychosocial assessment that comes along with that. And we also have a caregiver assessment. So people come in with their loved ones, if they have a family member. And so the caregiver does a separate assessment from the patient. And once we go through those assessments, people see a provider, usually myself or a nurse practitioner, and then they see a spiritual care provider as well as a social worker. The thought is that illness affects all parts of your life. It doesn't just affect your medical care or your physical sense of self, but it also affects your social sense of self as well as your psychological sense of self. So your ability to work, your ability to think, your ability to care for your kids. It also not only affects you, but affects everyone in your family. So for that means your caregiver, but it also means your coworkers, and it means your children, and it means your parents. And so we think a little bit about how do we care for the unit of care. So who's on your team as a patient, and how do we care for the people on your team in addition to you so that you get the best care possible? So we do that full assessment, and then we start and we just kind of do a deep dive into all of those symptoms and all of those care needs, and then slowly start to provide a plan for each of those things. And then we also do advanced care planning. So we do talk a little bit about advanced directives and goals, and we talk a little bit about making sure that you know who makes decisions for you, how you want your care to be carried out, who's in charge of things if you can't do something for a short time period. So we also make sure that we incorporate advanced care planning into that as well. So that's what a visit would look like, or first visit would look like with us in person.
I think that's great. And I think the advanced care planning and directives are one of the things that I think make patients a little uncomfortable, which everyone should have one. I have one, right?
Yeah.
I mean, I think it's proper planning for your future, because in the event I am unable to make those decisions, it's good to have somebody in line. So I think people shouldn't be afraid of those types of conversations. I'm curious too, because I remember, and as you know, and we talked Bonnie being my mom, and when she was diagnosed back in 2003, although she didn't see a palliative care specialist at the time, we had like family visits with her medical oncologist and her surgeon and her radiation oncologist and whatnot. And we'd all be sitting in the room and they'd be asking questions and she would answer. And quite often we'd be like, no, that's not what's happening. Right. So it would be very interesting to me to see how different the full assessment is in the beginning from how the patient's perceiving things are going versus the caregiver. In my personal opinion, the caregivers, sorry, Mom, I know you're watching, tend to be a little more honest about what's going on as opposed to the patient. So just a little comment there.
Yes, I could not agree with you more. And the story is
Yeah.
always multifaceted. So
Yeah.
yes, it's important to ask.
Yeah. So I do want to jump into the time of COVID. I feel like COVID. I said this last week, and I probably say it on a daily basis. Every subject line in my inbox these days seems to have COVID, in it somewhere. But it is our reality. I don't want to take away from the very real fact that we've got patients out there living with lung cancer who still want access to their treatments and whether it be, their chemotherapy or their follow-up scans or their palliative care visits. So in the time of COVID, what and how might patients be able to either continue and or initiate palliative care services And is it also that full assessment for the patient and the caregiver during this time as well?
Absolutely. I think none of us have lived through anything like this before. And for people with illness, I think it just increases the social isolation of already living with a serious illness. And it's interesting, though. I would say that for many of my patients, they're far more resilient than maybe even we are, because they've already coped with so many challenges in their life. They've already coped with neutropenic fever or having to isolate themselves from loved ones. And so there's a lot of strength in having gone through cancer treatment and having gone through a diagnosis of cancer that really gives them strength as they face this pandemic as well. I would say that now with COVID, for palliative medicine, we're busier than ever. I was just in clinic yesterday and I saw 15 patients. I interestingly wore my scrubs, wore my face mask, wore my white coat, and went to clinic and sat in my clinic room and looked at patients on the screen all day long. So I Zoom or video visit every patient, and we do everything virtually. We do all of our assessments as much as we can virtually. We don't get as much of the team visit in place because the technology hasn't allowed it quite yet, but we're working on it so that we can have multiple providers at the same time. But right now, we can provide excellent symptom care, excellent psychosocial care by telehealth. And it's interesting, a lot of what we do is talk to patients. It's a little bit less about physical exam and labs and radiology studies. So our skill is really in the communication, and our skill is really in understanding patients' wishes, goals, and experience. And so that can definitely be done through a telemedicine visit. For many of our patients who are frail or sick, who are struggling with mobility, or who just hate Bay Area traffic, which I would be one of those folks, they are thrilled. They're like, man, this is so much better than, trying to schlep my way to Stanford on a regular basis and valet park my car for $16 and, wait in, the waiting room for an hour. Like, I am glad that when it's my time, you log on, I have my cup of tea, and I can talk to you about the things that are most important to me. And so there's a silver lining in the COVID piece where I like to see people in their homes, and I like to see what they like to eat. And I like to see, where their caregiver is puttering around in the background. And I like to see the dog jump on their lap or the kid jump on their lap. And so it's something's really beautiful. It's almost like a home visit in the days of home visits.
Mm-hmm.
To really take care of people. And it's really removed some barriers. We have people from Turlock and Atwater and Pismo Beach and people who normally wouldn't make an extra visit for palliative care because they think of it as an additional service, who are now like, yeah, sure, why not? I'll get on another Zoom call. And so it actually has reduced some of the barriers to care and made people much more willing to give us a shot, to really see how we can help and assist them. And yeah, it's been great. So I wish I could see them. I wish I could give them a hug. I'm a hugger. So it kind of sucks to not be able to do that. But it's, I feel like to be able to at least still see people, and sometimes every week. There are some people I'm like, okay, let's talk again next week. Let's talk again next week because their pain's not well controlled, or they have depression that's really hard, or they're, working through an advanced care planning document and they're, talking to each family member in turn. And so it's been great because I can even see people more often than I used to.
That's great. Can you give an example, particularly from a telehealth perspective, one in maybe symptom care and one maybe in psychosocial care, on how you can actually help a patient over a video conference in those two areas, just like one example in each area?
Yeah. So symptom care, we see a lot of folks who have pain. Like that's a very common symptom that people have. And so one of our, the backbones of pain management is opioids. And so we do a lot of opioid. We can, do a pain assessment in terms of how severe pain is. We can do a pain assessment in terms of where the pain is located and what type of pain it is and how it affects function. I can often do something better than a physical exam because I can ask them to do things in their home and see how well they can do it with pain. So I can still get a pretty good, physical assessment of what's happening with the patient. And so after, we do all of that, we give them, a recommendation for a medication, and we can send that through, the electronic fax system to their pharmacy. And we say, okay, we're going to try this. We're going to see how it works. And then we're going to follow up in 1 week and see if it made a difference or not. And so anytime I start patients on a new medication for pain, I always see them in a week because I do not want my patients to be at home in pain. I do not want my patients to be at home in pain. And so if they're in pain, I want to make sure that it's better right away. And so when I start a new medication, my initial thing is, okay, I'm going to talk to you in a week. Tell me how it's going. If it's not better, then we're going to change things. And call me before the week is out too, just in case it's not better right away. And so then in 1 week, we, do a recheck. We say, is your pain down by 50%, 100%, 80%? And then we just make titrations and swaps based on what's right for that patient and where they're at. It's very doable, very easy. So that's the
This
kind
is
of a
great.
physical example.
Yeah. That's great. And I think some of the things that even I've learned, and I've been doing this and supporting, palliative care in the lives of patients for, a long time now. I think the way you explain it, and I'm hopefully the way that it's coming across to patients is something else that you said when we talked. Forgive me for quoting you every 5 seconds, but you said we were talking about lung cancer in particular, and you said lung cancer trumps COVID. And as a general rule, I mean, cancer trumps COVID, right? So finding these ways in these unprecedented times to be able to still care for the patient in whole, care for the whole patient, I think is so important. Whether it's allowing them to feel supported and connected to the healthcare professionals, empowering them to actively participate in their care, reduce some of those burdens that you talked about, whether they're travel or now even exposure burdens. I think it's genius the way that some of these that the way that technology has helped for those patients who might be worried about and or have privacy concerns. How is their privacy protected during, they're not just sitting in an office with you?
Yeah.
Are there special concerns that need to be taken into consideration?
Well, everything on the EHR is HIPAA protected, and all of the privacy features are in place for anything that's transmitted digitally. So that is nothing that we're so worried about. But, of course, patients have to be in an environment that they feel secure sharing information. So if they're in a public space, which I think none of us are these days, but if they were in a public space, then they would be compromising their own health information. And then for us, actually, a lot of our video visits still happen at clinics. So we go to clinic, we close the door, and we basically see patients who are at home, but we're still in a private, closed office. They are allowing us to do video visits at home now, but the expectation is that we still are, living up to that very high standard of no, HIPAA non-compliant paperwork around us, no nobody listening in on conversations, no children running around, but really being in a enclosed environment that's private to do those visits. So I think we really try to make sure that we do take care of people's privacy.
That's great. How can I'm one of my greatest hopes after folks see this and hear this conversation, either for the first time or because they've gone back and listened to it again, is that those who haven't will consider incorporating palliative care into their treatment plan.
Yeah.
Eventually we're going to get back to normal, whatever that may or may not look like. But during this time, how can a patient sort of initiate a palliative care appointment if it's something that they're interested while they're at home, living with some of these
Yeah.
challenges?
You had mentioned a little bit earlier about, not just the physical, but the psychosocial needs of patients right now, and how do we handle that? The reason I bring that up is that this is a really hard time. Like, we're struggling as a community. We're struggling because we're isolated and we're alone. And often when you have cancer, people are more protective of you, which means that you see fewer people, right? Like, you cannot go out, can't go shopping, can't see the people that you would normally see. And there's all these people who tell you, no, don't go anywhere. And so you're at higher risk for something happening if you get COVID. And so one of the things that I would say is that it's even more important to get palliative care involved right now, because that increase in depression and anxiety and adjustment disorder and grief, sadness, is very real in this time of COVID. And patients, you're not alone. Everyone's feeling it, right? Like, we're distressed as providers. We want to be able to see you and touch you and feel you and communicate with you. And so there's a general sense of increased sadness about the social isolation we're all in, and even making funky decisions about our own medical care. Like, well, I guess I'll hold off on going in to get that treated because I'm worried. And so then letting things drag out and getting sicker at home. So I think that there's a need to connect with palliative care more than ever, so that you can, manage the social and psychosocial distress that's associated with what's happening here and now. And it's very easy to access us. So at least in our academic system, you can just ask to be connected. And, we're getting in new patients every day to see people. And I think the same would be true for Sutter and Kaiser and UCSF, where even though the doors are closed for a lot of in-person visits, the doors are quite open for the telemedicine visits. So I would say, if you haven't connected, connect, because we can really help. And I have some patients who just tell me, Doc, can I just see you again next week? I'm like, sure, let's do it. And I think it just makes them happy that they're going to see someone in a week, right? Like, there's no guarantee that they're going to see anyone in a week. And so they're like, it just helps me to process. And I'm like, sure, you can see me in a week. We'll just, process what's going on with you and how things are going. And I had one lady the other day, she's like, no one gets what it's like. All I'm doing is blogging and tweeting. And I really just want to be in a place where someone else will just have a conversation with me about how I'm feeling and really understand what the cancer story means in the COVID story. Like, it's not just the COVID story, but it's, what does cancer mean within COVID? And to have a palliative care provider who gets that and who's able to really have a dialogue with you about it. So that's what she needed, and that's what we talked about.
I love that. I think that it's so important, especially right now, that patients are able to connect. And um, if I know anything, in doing some research for patients around the country and around the world, is most insurance or healthcare systems, if you log on, they have all the information you would need on how to access the telemedicine that they're providing. So I encourage everyone who is interested to do some digging into that. Or, of course, you can give us a call on our helpline, and we can try to help you navigate that in your area. This has been, I want to be mindful of time. We've got about 10 minutes left. A fantastic conversation, and I can't thank you enough for it. I'm curious if you have any final thoughts before I do some housekeeping and closing out of this meeting, I want to make sure that all of the amazing things you've said, that we haven't cut you off on anything you still want to say.
No, I'm just really thankful to be here, and thank you for the opportunity. I just, want to emphasize that we're really part of your team. Palliative care is really here to help and to make your care easier. There was a cartoon once about like a car that was moving from point A to point B without any shock absorbers or air conditioning or power door locks. And I think palliative care is really, it's air conditioning and power door locks and shock absorbers. And it's just making sure that when you go from point A to point B, it's the most comfortable it can be, and you have a sense of security and safety as you get there. So if you don't have palliative care involved, or your doctor's not doing a great job doing palliative care, which I hope they are, you can ask for it, and hopefully you can access it, and we're here to help.
That's awesome. Thank you so much. I just love you, and I'm sure everybody watching does too. I think you bring words and information to patients who really need it at this time. So a million thank yous for joining us today and being a part of that. I'm going to close out with a couple of things that I think might be even more relevant or might resonate more with some folks. And it's some of the things that GoTo can do to help support the in-between when you aren't maybe at your palliative care visit, but to help with some of that isolation and those feelings of, I just want somebody to get it. I want somebody that I can talk to who is living with cancer and during this time of COVID. And one of the many programs we have is our Phone Buddy or mentorship program, and we have a great team, patient support team, ready, willing, and able to help connect any of you with a like patient, as we can, to you and your situation. Someone that you can pick up the phone and talk to. Of course, there's social media, and on our GoTo Foundation for Lung Cancer social media platform is loaded with patients. Our online support groups that we have through Health Unlocked and Belong, sign up on there. Our telephones, our support group network, which is a national network that the team has done an amazing job of pulling together so that you can find a lung cancer support group in your area. We've been updating during the time of COVID to see who's still having meetings, either via Zoom meetings, video chats, or even telephone meetings. Please check in there for something in your area. And then, of course, our helpline, where we have dedicated staff, expert staff. There's the number that just came up, at the ready to answer any questions that they can. And if they can't, they will point you in the right direction, in order to get those questions answered. So please don't forget that some of those in-betweens, when you don't have the benefit of a Dr. Ramchandran at the other end of the telehealth line, we are there, and we do have programs available for you. So with that, I'm going to let you guys know that our next Rapid Response Living Room is May 5th, which is next Tuesday, 1 o'clock, same time. Dr. David Gandera from UC Davis, who most of you know from the living room. He's been sort of a standing a guest on the annual basis since we've started this. So he'll be here next week to talk a little bit about some of the delayment in care concerns, as well as how you might be able to use telehealth at this time for your treatments as well. For events, like I said, the events team has been working fast and furiously. And although I don't have the link on me right now, you can go to our website to find out what's going on. They've been doing a lot of really innovative things to try to make up for a lot of the events that I know so many of you look forward to every year, including a 30-day challenge. So please go to our website and look into that. Again, a huge thank you to you, Dr. Ramchandran, for coming and talking with us today. This has been fantastic. Thank you to all of you who are watching live, or who will come back and watch post live. Thank you to Peninsula Television, as always, for helping us to put on yet another great show. And stay tuned for information about how we'll be evolving this rapid response living room, and bringing back in maybe regularly scheduled third Tuesday of the month evening living rooms in combination or some combination thereof. We should be able to announce that pretty soon. Of course, last but not least, a thank you to all of our supporters: Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Bristol Myers Squibb Foundation, Genentech, Lilly, Merck, Novartis, Oncocyte, Takeda, and Foundation Medicine. Without your continued support, we simply would not be able to do it. So thank you all. Enjoy the rest of your afternoon or evening, wherever you may be watching from, and we will see you next week. Thanks, everybody.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.